what is the basics of septic shock that we need to know? One is the definition. So the definition involves two parts. One part is that you have an increase, you have a requirement of vasopressors despite fluid challenge. That is one part of the story. When you say septic shock, you say that you need the requirement of vasopressors. That's not right. That's not right. Listen. Okay. You need the requirement of, there's no point of writing all this in there in the books. It will be done on the website also. So any patient who requires vasopressors in spite of a fluid challenge, to keep the MAP more than 65 is one part of the definition. What is the second part of the definition? Lactates. The lactates going more than 2 millimoles. Okay. So when you talk about septic shock, these two parts of the definition should be intact. The first part of the definition is, okay, this patient has got a MAP of more than 65 despite a fluid challenge. Okay. And the second thing is, you have a lactate of more than 4 millimoles. Take the example of the patient that you were talking about in the morning. So the MAP is low. Okay, the MAP is low. You have given a fluid challenge. It has not improved. You have to start a vasopressor. You send a blood gas, it goes more than 2. This goes in favor of septic shock. This is a definition. It doesn't mean that it needs to have all of these things. Many times it happens the lactates are low. Many times that the MAP is not really high. But you know, this is the broad definitions are helping you to understand the situation. Okay, if you have a clear-cut situation where the blood pressure is low, you are resuscitated and the lactates are high, it is septic shock unless you find something else in the picture. Clear on this till now? So when you say, so understood this till now, what are the definitions? The first thing you should know. So in your exam, if it comes, a big question comes and says, this is the you should be able to relate what we are talking. We are talking of the definition. Okay, lactates more than 2 millimoles. Okay. So now, once that comes in, the first thing that you should think about is this a sepsis mimic or not? Which other conditions will look like sepsis, septic shock? Which other conditions? So there are many conditions that look like sepsis and septic shock. Many conditions. A simple glomerulonephritis will look like septic shock. An catastrophic apla will look like septic shock. A cardiogenic shock at times will look like septic shock. There are many pathologies that will look like septic shock. So you should be able to rule out a sepsis. Okay, you might say this is not sepsis, that's not septic shock. So now when you come to the diagnostic investigation, so there are focal diagnostic investigations and there are general. So when you say general diagnostic investigations, the general diagnostic investigation will require a CBC, isn't it? A general diagnosis is CBC. Okay, very general. So any patient that comes in, irrespective of whether it's septic shock or not, you will do a CBC. So it's a very general investigation. When I say focal, it means I am looking at, say for example, this patient had an altered mental status. I am looking at meningitis. I am looking at a CSF. If I have a patient who's got necrotizing fasciitis, I am looking at specimen coming from here. If I am looking at a patient who's got pyelonephritis, I am looking at investigations from the urinary tract. Clear? So general investigations may first will have CBC, and the importance of doing a CBC is to figure out how severe the entire problem is. And how do you find severity in CBC? By looking at neutrophil lymphocyte ratio. Okay, if the neutrophil lymphocyte ratio is more than 10 or more than 15, if it's more than 10 or more than 15, then you're looking at a severe situation. Sachin, can you make a glass of coffee? So if you have a neutrophil lymphocyte ratio, that is if it's only without sugar. So if you have a neutrophil lymphocyte ratio that is more than 10 or more than 15, then you will call it as a severe kind of condition. Now you must understand there are certain policies when you look at that. If you have febrile neutropenia, how to look at this? If it's neutropenia, which is a part of septic shock, which is from cancer chemotherapy, or patient has got leukemia, you can't look at neutrophil lymphocyte ratio. Obviously you can't look at it because the cell lines are changed because of the disease. You're understanding? So you can't figure out with the neutrophil. So it's not that neutrophil lymphocyte ratio every time will give you the answer. It will give you the entire element of physiological stress that the patient is facing through. So it's not a diagnosis of sepsis. It's a diagnosis of physiological stress. Okay. So if the patient has got stress, pathological stress, and stress that is patient is probably going to go down majorly, then your neutrophil lymphocyte ratio comes in place. Clear? You can't interpret it in neutropenia. You can't interpret it when you have the patient who's having cancer, malignancy. You can't interpret it on all those times. Clear? So this is your general investigation, CBC. Okay, it also gives you, say for example, you've got some kind of hemoglobinopathy which is causing septic shock, B12 deficiency or things like that. That also give you by looking at MCV. Okay, so it's going to give you a lot of other things that the CBC gives you. Now, apart from that, the general investigation you think about is any kind of inflammatory marker. Another inflammatory marker that points towards sepsis is CRP and procalcitonin. Okay, these are both general markers. Now, if you were to ask me what is the difference between both of them, the CRP is a marker that is extremely non-specific. Extremely non-specific. You understand? CRP will go up even if I have a small viral infection. CRP will go up even if I have an inflammation of my toe. CRP will go up even if I have a small atelectasis. You're understanding? An inflammatory marker is very, very non-specific. It doesn't point towards any bacterial etiology. Clear? It doesn't point towards any bacterial etiology. It will not say that, okay, CRP is elevated, so it's bad. But what we know is if the CRP is in the ranges of 100, then this patient is very sick. If the CRP is in the range of 100, if the patient is very sick, it just gives you an idea that how sick this patient is. And as time goes, you'll find out, okay, your CRP was 100, it has come down to 20. You can understand the sickness is actually coming down a little bit. Are you understanding? Are you understanding? So, the other part of the story is procalcitonin. So, what is procalcitonin? It is basically released, it is a precursor of calcitonin, procalcitonin comes in. And this procalcitonin also elevates when there is a severe stress. That is also important for you to understand. Okay, it elevates. So generally, if the procalcitonin is less than 0.5, it will cast a doubt on your diagnosis of septic shock. Generally, if a procalcitonin is less than 0.5, it will cast a doubt. You can still not say for certain, but it will cast a doubt. You will say, why is septic shock? Is the chances of it being septic shock are less likely because it is 0.5. It is not no. It is not yes or no. It is casting a doubt on your diagnosis. You are understanding? So if a procalcitonin is 10, then probably you are in the right track if you are thinking of septic shock and this might be septic shock. Might be. Again, not a diagnostic tool. Tomorrow you have a patient who is lying down over there, his blood pressure is 100 and a patient had a fever spike, you said a procalcitonin, it comes as 10, you can't diagnose sepsis. You can say maybe this is sepsis. Clear? Maybe this is septic shock. Clear on this? You are understanding the thin line between what it is and what it is not. So that is why procalcitonin has never been used for the diagnosis of sepsis. So for example, you have a viral fever. And you do the procalcitonin, the procalcitonin comes as 0.25. You can probably think maybe there is no bacterial sepsis here. Maybe. You understand? That is because how the procalcitonin release? It releases with the use of interleukin 1 beta and TNF alpha. That is when procalcitonin releases. Interleukin 1 beta and TNF alpha. That releases. And that's why this. But what happens in viral fever? You have the release of something called tumor necrosis. You have a reduction. So interferon beta is released. Another interferon is released. When another interleukin is released, the tumor necrosis factor comes down. Another kind of interleukin when it releases, okay, it actually drops the tumor necrosis factor. That's why mostly in viral fever you will not get the procalcitonin going up. So I'll explain this once more. Interleukin, in the various interleukins that are released. Many of these interleukins actually cause, together along with TNF alpha, causes the inflammation. So that inflammation is responsible for the procalcitonin to go up. And the incidence of inflammation going up is when there is bacterial infection. You understand? So when there is bacterial infection, interleukins are released, TNF alpha is released. And that's why these patients get a procalcitonin that is severely elevated. Right? However, in viral sepsis, what happens is it actually causes another interleukin to release, a different family of interleukin to release, which actually causes the tumor necrosis factor alpha to go down. So that's why the chances of procalcitonin going up become less likely. You can't say for certain. Clear? That is why procalcitonin is never used in the diagnosis of sepsis. What is this used for then? It is used for maybe a trend maybe. Okay, you do a procalcitonin and then you do a procalcitonin again. You can get an idea, okay, this is probably trending. An idea, again, nothing specific. Idea that this is probably going up and I need to probably do something better. I need to probably tackle the source. I probably need to change the antibiotics. It's probably not doing well. It gives you an idea. But at the end of the day, it's a clinical know-how that helps. Clear? Importantly, procalcitonin, if you send too early in the disease, you'll probably not get an elevation. Okay? The procalcitonin usually starts elevating from 6,000, reaches a peak at 24 to 48 hours. Clear? So there again there is a problem. So there are too many question marks in procalcitonin. You understand? So if you send the procalcitonin early, you may not get the elevation. You send the procalcitonin after 24 to 40 hours, then only you get the elevation. So there are a lot of things that comes with procalcitonin. That's why procalcitonin is not used in the diagnosis of sepsis. We don't really want to even trend sepsis per se because we're not certain about how it is trending. But it is important as a de-escalation tool. So what happens? You have a patient who is on septic shock, and you've given him antibiotics and you've given him whatever needs to be done. And now it's day 7, day 8, and you feel this patient probably we should get off the antibiotics because patient is doing well clinically. Patient is clinically doing well, supports have moved off, patient is looking better, patient is having food, looks stable, patient is sitting on a chair. So now you want to get off the antibiotics. The question is, do I get off the antibiotics or don't I? Okay, now that is a difficult call to take. Whether you want to take it or not take it. So one thing that helps you in this case is to do a procalcitonin. So here we'll do a procalcitonin with less than 0.25. Then you can, it gives you good guarantee to get off the antibiotics. So de-escalation of antibiotics work very beautifully when you use the procalcitonin. That's why if you notice, we normally look at procalcitonin towards when the patient is clinically getting. You can't do like this, that the patient is clinically not getting better. It is 10 days of antibiotics. I'm going to send a procalcitonin. It doesn't make sense to de-escalate that time because the patient has to first clinically get better. When the patient gets clinically better, then only we can think of this anything. So any doubts on procalcitonin? Any doubts? Any doubts on procalcitonin? You've understood this. So in certain cases, it will go up without anything. That is medullary carcinoma of thyroid because it's produced over there. Without any reason, it will be haywire. It will not be. Then in patients of say meningitis, in patients of localized infection, for example, there is a small localized infection sitting down like an abscess. In that case, there is an abscess lying over there. It will not show because it is localized. You're understanding now? For example, this is a perinephric abscess lying over there. It may not show because it is a localized abscess, a deep-seated abscess. So normally this procalcitonin is for abscesses for infections that are around, like for example a community acquired pneumonia. Are you understanding? So you may not get a So if for example if you feel that there is a small abscess lying somewhere else, localized somewhere, you may not get the PC to be. Similarly in meningitis, you may not get the PC to be called. Though it is sepsis, it's an infection, but you will not get it out. Clear? Any doubts here? Any doubts? Any doubts on procalcitonin? Any doubts? Anyone?
So in COVID, you see PCT levels.
So now what I explained to you based on that, can you tell me? Well, Elizabeth, can you tell him what happens? So COVID is a virus. So on basis of that, what is the relationship to PCT?
What Sir said was in bacterial infections, what happens is a cytokine, cascade that happens. So IL-1 goes up, then there's the tumor necrosis factor also that goes up, and thereby it promotes the PCT also to go up in bacterial infection. In viral, what happens is the reverse happens. The tumor necrosis factor goes down, and therefore the PCT also dips. You may get a low PCT.
You may get a low PCT. So you cannot be certain by doing, but you cannot differentiate also. You cannot say that today I got low PCT, so this is a viral infection or this is not bacterial infection. Because that discriminating power is not there for procalcitonin. You understand? Discriminating power is not. It only guides you. So you don't use procalcitonin as a diagnosis or a marker saying this is sepsis or the diagnosis. It is used to understand sepsis. It is used to understand which way we are going. It is understand to give you kind of a guidance. At the end of the day, what you are realizing is sepsis is more of a clinical diagnosis. Are you understanding? It is more of a clinical diagnosis where you understand that there is a pneumonia, the blood pressure is dropped, you've given fluids, it's not improved. You start a vasopressor and then the lactates come back as say 10. You got the point? So that is how you diagnose septic shock. Any queries now on this? Right from definition to the diagnosis. Any queries here? Any queries?
So like when you say a patient, say supposing a patient has UTI, patient is in neurosepsis, so what we mean to say is this is a life-threatening organ dysfunction has happened.
That is definition for SIRS. That is definition for sepsis.
Yeah,
this is definition for sepsis. So when you say septic shock, means what is happening? I have given fluid. In spite of that, the MAP has remained less than 65. I have to start a vasopressor to keep the MAP more than 65. And my lactates are elevated. So two parts of the story. First part of the story is I have given fluids to keep MAP more than 65 and started vasopressor to keep it up. And the second part of the story is lactates going up. So that is why when I come to see a patient of sepsis and septic shock, when you not sent an ABG, I feel you should do ABG. Let me see the lactate. You are understanding, huh? Are you understanding? Because it gives me 2-3 things. It makes me understand the severity. It puts me in the definition. Definitions usually are not created just for the sake of defining. It's also created for clinical trials. So tomorrow, if you want to do a trial of septic shock or certain medicine versus other septic, so you need a trial, you need a definition. So that's one of the reasons that definition is also created, and also gives you guidance as to what is to be done further. You understand the lactates are elevated. I repeated, I found the lactates lesser. I tend to believe that okay, the patient is doing better. Again, there is a problem. Lactates will not get elevated in every disease. Okay, lactates will get elevated when there is epinephrine on. So that's why I sent the lactates earlier. Lactate comes up whenever there is going to be sympathetic response. Whenever your endogenous epinephrine is going to increase. That these are the problems with the definition. The definition says that the lactate should be high, and the lactate should be not, or the lactate should be high. It says and the lactate should be high. Now the issue is what? Say you have a patient who's very sick, who's extremely sick. When he's extremely sick, he's bradycardic, not even tachycardic. When he's bradycardic, means he's very, very sick. Okay, if he's bradycardic, it should be actually tachycardic, because cardiac output is equal to heart rate into mean arterial pressure. And if mean arterial pressure is low, the heart rate has to go up. If that simple thing is not happening, that means this patient is very, very sick. You understand? This patient is the flight and fight response is not working. In that case, your endogenous epinephrine is not getting released. Your endogenous epinephrine is not really released. One of the places lactate goes up is because of endogenous epinephrine. So if your lactates are alarmingly low and the patient is sick, actually you don't need something definition to tell he's sick. He's sick. That means this patient is very, very sick. So this doesn't fit into the definition of septic shock, but it is septic shock. Are you understanding? It doesn't fit into the definition of septic shock, but it is septic shock. Similarly, you have another patient whose BAP is around say 60, 65. He's a patient of liver cell failure. Now in a liver cell failure, they don't produce lactate because of D-lactic acid. They don't produce that lactate. They are producing lactate. At the same time, what is also happening is he has lactic vasodilatation. That is because of his portal hypertension or whatever. So you can again, and he gets and you might think that this is sepsis, but it is not sepsis. Are you understanding? So that is why definition has to be taken care of. You must be careful of the definition. So tomorrow, if you have a patient who comes in and you have started the patient on epinephrine in the casualty, 6 hours later you decide, let me set a EBG with lactate. The lactate going up may be part of the epinephrine that you have given exogenously. Are you understanding? Are you understanding? So this is a problem with the lactate. That is why even when you are trending the lactate, there is a problem. If a patient is on epinephrine, the trending of that lactate becomes a little bit difficult. समझ में आ रहा है? Because epinephrine will cause the lactate to go up. समझ में आ रहा है? Sachin, are you understanding? So it's not easy to actually just do something. It's so complicated that you have to think all sides of the story. That is why it is very important to be a bedside physician. All these things will help you. But unless you're a good bedside clinical physician, you can't really do anything. So when I come to bedside, there is a very important thing that we want to look at when it comes to shock. What is our end points? Okay, how do I understand? Now I understood how to understand this patient is sick. एक तो hypotensive है, plus he is basically requiring vasopressors. That is lactates are elevated, procalcitonin is very high, NL ratio very high. This patient is sick. He is very sick. I don't need anything to tell me that he is very sick. I have finished all these things. He is very, very sick. Now, when I say fluid resuscitation, when I say fluid after fluids, so what is that amount? That amount by definition is 3 liters, 30 ml a kilogram approx. Okay, 30 ml a kilogram. So that when I say even after fluid resuscitation, the MAP has remained low. So vasopressors, even I have started vasopressors. That means to say which is that fluid resuscitation? 30 ml a kilogram. Clear? So by definition, the Society of Critical Care Medicine Surviving Sepsis Campaign guidelines have actually said that the definition should involve 30 ml a kilogram fluid resuscitation. Clear? Of course, again you must now, it's very obvious that if a patient is in heart failure as in sepsis, I'm not going to give 30 ml per kilogram, right? Though the definition says that. Even if you look at the definition and you look at those patients, when they created the definition, there was this question: what if the patient has end-stage renal disease and not passing urine? What do I do? You still give that 30 ml is what they say. In the definition. For the definition, they still say, so don't confuse yourself. What I'm telling you, you understand very carefully. What does the definition say? Even after fluid resuscitation, the MAP remains less than 65, I am giving vasopressors to keep the MAP more than 65. This doesn't mean that I am going to give fluid resuscitation over 6 hours. I am giving a fluid resuscitation quickly. Within say maybe 40-30 minutes, I'm going my 3 liters has gone inside and patient has not responded. That's why I've started MAP. I've started my vasopressor. Right? समझ में आ रहा है? So that fluid resuscitation, tomorrow you will say there is a patient of end-stage renal disease. You may say there is a patient of cardiac failure. How will I give 30 ml per kilogram? You will say like that. No. Let's take 2 parts of the story. The definition. The definition of the SCCM says give it. Even if the patient is ESRD, even if the patient is congestive cardiac failure, you still give that fluid, is what they say. Okay, what we do practically is different. What we do practically is we observe. We have got ultrasound, we have got so many other things. We are doing all those things and figuring out what we should do. Like for example, yesterday's patient. We know she's in sepsis. We know she's in sepsis. We know she's developing fluid effusions. But we still gave her fluid. Clear? So it's not something that. Similarly, yesterday, her blood. So you got the point what I'm saying? So everything has to be individualized and personalized. Though the definition says this. So tomorrow, if the definition says you have to do it, if you want to do it, whether you say you do it, you can do it because it's a definition. Nobody's going to tell you wrong. Because the definition says so. And why is it saying that? Why is the definition saying that? Because sepsis per se is a vasodilatory condition. They get dilated. So you don't need, IVC is going to be collapsing, heart is going to be hyperkinetic. By looking at the IVC, you are not looking at whether the patient is going to be fluid responsive or not. And you're not even judging whether the patient is hypovolemic. Are you understanding? Tomorrow if I have a full IVC, I have a congestive cardiac failure patient with a completely dilated IVC. If I take a deep breath, my IVC has to collapse. Are you understanding? My IVC has to collapse if I take a deep breath. You are understanding what I am saying? So IVC collapse is not the indicator to decide on fluid. IVC collapse is not the indicator to decide on fluid management. Clear? Clear over here? Why am I again stressing this fact? Because where have I mentioned about IVC anyway? Okay. However, they do mention that when you are giving your fluid resuscitation in the definition of fluid responsive state, they mention when you are giving a fluid resuscitation, look at these parts for guidance. Look at your IVC, look at your 2D echo, look at your extravascular lung water index. They tell that. Got the point? You look at that, guide it. Clear? Clear now about that part of the story? Now the other part of the story is, okay, clinically I want to figure out how is this patient. So I said lactate was one thing that we were looking at. We looked at a map of less than 65, this is lactate, but there is capillary refill time which is supposed to be better than lactate. There is capillary refill time that is actually better than lactate. Are you understanding? The capillary refill time is actually better clinical indicator than the lactate. And how do you do this? By definition, you are supposed to take a slide. By definition, if you want to do an actual capillary refill time, you take a slide, put the slide on, completely blanch it out and then look. Completely blanch it out, then release. So look at it. Okay. So when you see it, you will see if it is more than 5 seconds, the capillary refill time is markedly delayed. Like yesterday's patient. Yesterday there was the patient who got malaria dengue. That patient's capillary refill time was markedly delayed. It was 6 seconds, 6-7 seconds capillary refill time. 6-7 seconds capillary refill time. Okay, that was what it was. Clear? So I don't need anyone to tell me that this patient is probably going bad, he is very sick, he is in shock, he is in cryptic shock. Though his blood pressure was normal, isn't it? Blood pressure was, that patient is so interesting. His blood pressure was normal. His blood was normal, 120 his blood pressure was. Okay. But when we did a capillary refill time, what did we find? That was markedly prolonged. What did that trigger in this case? Giving fluids. Are you understanding? It triggered you. Now we correlate that to the lactate. What was those lactates?
Lactates were 9.
9. No, it was not 8.
Lactates, Bica were 9.
Bicarbs are lactate 20. See, now corresponds. No, lactate is 20, bicarbonates are low. Though his blood pressure is normal, so this is not fitting into the diagnosis of septic shock. Though it is, we are treating it like septic shock. Clear? We are resuscitating like that. Clear on that? Clear? So capillary refill time becomes very, very important. Then what are your targets? Your targets over here, whenever you are cleaning up, when she talked about septic shock, your targets were important. So what is your target? Your target has to be the mean arterial pressure. The target is that when you are having septic shock, and you want to do something, your first target is mean arterial pressure, right? So mean arterial pressure has to be maintained more than 65. That is the target. Okay, more than 65. So today, if you have a patient on noradrenaline, the target is MAP is showing less than 65. And why is MAP the target? Because MAP is closest when you look at NIBP or arterial line. When I look at oscillometric method or you look at the arterial line method, the is the closest. You understand? If your MAP, even if your blood pressure is 140 and your MAP is 40, this patient is going to go down if you don't get the MAP up. Even if your blood pressure is 140 and the MAP is 40, this patient is not going to improve unless you get the norad up. So that's why systolic blood pressure is not something you want to see. I want to see by mean arterial pressure. Clear? Mean arterial pressure. So simple. Keep the MAP more than 65. This doesn't mean that I will first give the fluid and I will see what will happen and let the MAP come up. No. The answer is simultaneously when the fluid is given, I have to start my noradrenaline because that is the vasopressor of choice simultaneously. So you understand the mistake, morning? What did you do?
Fluid resuscitation.
Then you started noradrenaline. So that is a pure mistake, clear mistake. In the night, this patient had a drop, some time ago. So you should have done what?
Simultaneously.
You understand? So this is a very important point that I'm trying to tell you because you practically are making this mistake. Today also there has been a mistake in the ICU. Okay. So whenever you have a patient of shock and you're certain this is sepsis, I will start my noradrenaline, continue my fluid resuscitation, and then reduces if it required. But I have to keep my MAP more than 65 at every given moment. Right? At every given moment, that is why I told you to put a arterial line. समझ में आ रहा है? Clear on this? Huh? Clear? So your trigger will be, you see an NIBP showing 60. This is a case of septic shock. We're not looking at other diseases, we're looking purely septic shock. Mean blood pressure is 60 and I put an NIBP, the MAP is showing 60. What I will do next? Give fluid, give vasopressor, start right now and put an arterial line. And there is no two things about it, not to think. This is clear. Clear? Now your mean arterial pressure does not go up. It has not gone up. Okay, simultaneously, what will you do? What will you do in these cases? I will start adrenaline. I have started noradrenaline, which is a vasopressor of choice. But if it has not gone up, I will start vasopressin or adrenaline. Vasopressin, if I want, I can start vasopressin. I will start it. And I will not titrate my vasopressin. Why? Vasopressin has to be given at 0.04 units per minute. It is not titrated. Why it is not titrated? Because the half-life is 30 minutes. The half-life of vasopressin is 30 minutes. So you can't titrate it. I mean, 1 ml kiya. No, BP has not come up now, let me make it 1.5. It is not like that. Because the half-life is 30 minutes. 5 times the half-life remains in the body. 5 times the half-life, it takes for to excrete out. So it is for a long time inside the body. Are you understanding? So you can't titrate it. It's funny when I come and see, आज 1 ml चालू किया है, सर मैंने रात को 1 ml कर दिया उसको. क्यों किया तुमने 1 ml भाई? There is no titration only. Based on what have you titrated? There is no titration of vasopressin. You either start it or you stop it. You understand? Huh? So over a period of 12 days, also patient doing well. So when you are starting, there is no titration. When you are stopping, maybe you can give it over 12 hours and then stop it off. Are you understanding? Huh? So when you are starting, there is no titration. You started at 2.4 ml per minute, which is basically 0.04 units per minute. Are you understanding? Huh? Clear? So there is no starting. So you can't start, I'm starting as well and see what happens. Clear, Sachin? You are understanding this. When I start norad, I don't see the blood pressure coming up. I don't wait for 15 minutes and 20 minutes. I don't see. Noradrenaline is immediately titrated. You start norad, BP will come up in the next minute. If it doesn't come up, I start vasopressin. Right? It doesn't come up, I start adrenaline. But I have to start. I have to keep the MAP more than 65. Clear? Then the next thing I do in these cases is simultaneously, I actually start the patient on serum. This is septic shock. I don't have to think here. I have to start the patient on steroid. How do I start the steroid? I don't start it at 200 milligrams of 50 cc over 24 hours. I will first give the bolus. It has to spawn inside. Well, I want the effect to come now. So at 50 milligram I will start. I can give 50 milligram every 6 hourly. You understand? I cannot wait. I cannot start that infusion and start at 2 ml per hour. 2 ml per hour means it is going to take a very long time before that 50 milligram goes inside. It will go more than 6 hours before that 50 milligram goes inside. समझ में आ रहा है? So what I will do? I will immediately give that 50 milligrams of hydrocortisone and then start an infusion. Meanwhile, I will ensure that the MAP goes more than 65. Clear? Clear on this? Am I clear on this? Any queries? Any queries till now? Any queries till now? Before you do this, when we were going to our examination findings, we said there is also a general and a focal laboratory that we are going to send. So in the general laboratory, it will also involve the CRP, PCT, the general laboratory, CBC, the general laboratory finding, general laboratory they are going to send. And the last thing is blood cultures. So when I say blood cultures, I am looking at 2 sets. When I say 2 sets means 4 bottles. When I say 2 sets means 4 bottles. 4 bottles means 40 ml. Remember this, every ml will increase your chances of getting a culture positivity by 1.25%. Every ml. So if you send 2 bottles, how much will you get? 25% sensitivity, 30% you might get it. When I send 4 bottles, I reach 50 plus. When I reach 4 bottles, that is when I reach 50. You understand? Each ml of blood that I am sending for my blood culture diagnostic abilities will improve by 1.25%. Okay, now when that occurs, if I send 10 ml, 8 ml, I am getting 10%. If I am sending 8 ml, I am getting 10%. If I am going to send 16 ml, it's going to be 20%. When I am going to so when I will reach near about 50% when I am going to send how many bottles? So what? So the site has to be if it's a peripheral site, you add from the same site. If it is just, if the patient has come like that to you without anything, you want to diagnose blood, so I don't want from different sites. I am going to take it, इधर से ही collect कर दिया मैंने, एक ही collection में 40 ml I've taken out. 40 ml out of 5 liters is not going to cause anything to this patient. It is not going to drop blood pressure. 40 ml comes out from here, 10 ml, 10 ml, 10 ml, 10 ml, 4 bottles it goes. But if the patient has got a line that is more than 48 hours, if the patient has got a line that is more than 48 hours, it has to go, one set has to go from that line. You understand? If there is a line of more than 48 hours, one set has to go from that line. So have we sent from that line yesterday's patient? No. So one set has to go from that line under sterile precautions. Clear? All of this is done as sterile precautions. So that's your general investigation. In a septic shock, if you don't send a blood culture, you are not doing the right thing at all. It's a very general investigation. It doesn't need you to be focally looking at something. Then the focus comes. Then, for example, you have an empyema, you have an abscess sitting somewhere. Then your clinical examination will come to your, okay, this patient probably has got your urinary tract infection. Now let me look at urinary culture. By that time you have done your ultrasound, you have taken your history. This is a patient who's just come in. So don't comment, okay, kya hua, okay, kya hua. That doesn't make sense of me. Patient comes from the casualty, you are taking a history from the casualty medical officer when you are understanding that actually this patient is worsening by the minute. It doesn't make sense of me. Are you understanding? Like yesterday's patient. I went for a round, I came back from the round and nothing was done. When I say nothing is done, it means to say what is occurring now on the background. On the background, the kidneys are failing. We don't know. Tomorrow, kidney functions deteriorate. Background kidneys are failing. And how do you know? You send a urine routine microscopy the next day, you'll probably get muddy casts. If you get muddy casts, you are certain that this patient is developing acute tubular necrosis. Are you understanding? So this is something that you must understand. It is time bound. All this resuscitation, sepsis resuscitation, septic shock resuscitation is time bound. You don't do it now, later on I cannot come and correct it. It is done, damage is done. Are you understanding? Damage is done. That is why we are saying do this quickly. Okay, the resuscitation has to be quickly. Okay, because what happens is then you do whatever you want. Put the patient on CRRT, give higher generation antibiotics, do all these things. Patient is going to go down. Are you understanding? There is no point. You got the point. That is why septic shock is a medical emergency. You can't treat it like any other case. It is a medical emergency. I have to ensure that my stuff is done. So that is why quickly I have to get my IVC because it's a part of my fluid resus. My IVC to see whether it has got suddenly dilated, to see whether whether this is not pulmonary embolism, which actually looks like sepsis, to see that there is no cardiac tamponade, which also looks like sepsis. Okay, I do my V lines to understand whether there is an element of. I do my lung ultrasound to figure out whether there is an element of pneumonia there. I don't have the time. Chest X-ray aana baki hai. Chest X-ray will take its time, but the ultrasound is my investigation at that time. I'm quickly doing my entire ultrasound to figure out this. I'm also looking at whether there's an increased prevalence of B lines over here, which is basically excess resuscitation that is occurring. Are you understanding? So it is not something that I can stand in my room and do. It has stand on another side and do. It has to be bedside. Few things are bedside. This is one of the things that are bedside. Okay, so this we have come to. Then the next thing that comes is I want to give an antibiotic. So once I have done these few things, laboratory, focused laboratory, first we did general laboratory, then focused laboratory. Focused laboratory was, okay, you had a patient who basically had a pneumonia, I intubated this patient, I sent a ball, I sent a mini ball. That's focused laboratory. Focused laboratory. Clear on this? Huh? So you need to do the focused laboratory after your general laboratory. Huh? Any queries till now? Any queries? No queries, right? So
did we apply that QSOFA score for the assessment of?
You can do it, but QSOFA is only to diagnose sepsis. Where are we now?
Septic shock.
We are septic shock. We are in another syndrome now. QSOFA is different from septic shock. QSOFA is sepsis. Sepsis is life-threatening organ dysfunction. It has not occurred. This has occurred. This is beyond that. This patient has got a higher chance of dying. That patient has got a lesser chance of dying. You are understanding?
Sir, how do you reassess whether the patient is improving?
That's what I told you. That's exactly what I told you. So first is the map has gone up. The supports have started coming down. The patient's capital refill time has improved. The lactates have come down. That's what I told you basically. Urine output has improved. Very important judge. After your MAP, after capital refill time, the very important judge is your urine output. If the urine output is more than 0.5 ml a kilogram, you're probably doing well. Are you understanding this? Very important. So your note should 3-4 hours later involve this part of the story that says the map has come up, the supports have come down, it is regularized. This has come. So the shock index becomes very important. Your heart rate divided by systolic blood pressure becomes very important. Okay, you understand from there also whether the patient is getting better. Okay, so there are many reasons to say that the patient is clinically getting better. So clinically, patient's respiratory rate has improved. Patients, because his acidosis has come down, that is why he's improving, isn't it? Lactates have come down. So these are the things that you will probably capital refill time. Urine output is 0.5 ml a kilogram. It has started improving. Like yesterday, there was no urine output for at least 2 hours, and then suddenly he passes urine. So I am now certain, okay, my resuscitation has done well. Are you understanding? Other way around, in yesterday's patient, we wouldn't have resuscitated. What would be the situation now? He would be on a ventilator now. Though he can still be on a ventilator, but now he would have been on a ventilator right now. He would be on a ventilator for certain. Are you understanding? Today's heart rate has come down without evaporating. Without evaporating, his heart rate is down. Are you understanding? Whereas the other side of the story, the other lady, her heart rate has not come down, so she is not improved. So when you answer your question, that patient has not improved. Both similar patients, that patient has not improved. So I need to do something further. I need to probably give my antibiotics. Maybe I need to increase the MAP. You understand? So in the night only he would have increased the MAP. In the night only he would have increased the MAP. He would not be in a condition where the pulse rate was fast today. Are you understanding? Huh? Clear how we miss the bus if you don't know the definition there? Clear? So you understand the importance of the definition now? So you would have diagnosed that patient as septic shock in the night itself. If you would have capital refill, done a blood gas, understood the patient, you would have started noradrenaline because you don't need to have low blood pressure. And you probably resuscitate, you probably start the antidotes, vasopressors. Clear?
So for the definition, first you fluid resuscitate and then if the BP doesn't improve.
No, it is simultaneous.
If it's simultaneous, so then the definition but said that post resuscitation with vasopressors.
Yeah. Suppose resuscitation. Resuscitation, how much time it takes? That's why I tell you it cannot be a resuscitation that is taking 6 hours. 50-30 minutes you have done it. In 30 minutes you have...
30 minutes, in that we don't start NORAD or do we
You can start. You can start. So we don't want even 5 minutes of low blood pressure. No. We don't want even 5 minutes of low blood pressure. But the thinking that I will first resuscitate and then I will give vasopressors has been debunked some years ago. When the sepsis definition came in, this was what they told us. You first resuscitate, give 30 ml a kilogram. If the blood pressure doesn't come up, then start vasopressor. This was what the thinking was. When we did that, whenever a definition comes, whenever something comes, then there is a huge audit that happens all over the world. People do audits here and there to see what is happening. They see what the mortality has changed or not changed. It didn't change. Then they did a study that said, let us give upfront vasopressors. Let us give upfront vasopressors. So when they did upfront vasopressors, there was an improvement. You understand? So now the definition which is old, it still says it, but with a small modification saying that I will simultaneously start the patient on vasopressors. You understand? So the thinking that I will fill the pipe and then I will constrict the pipe, that was the first thing. I fill the circulation and then that is wrong. So that's why we did. That's why we don't need to start putting a central line. We can start this noradrenaline peripherally. You start the noradrenaline peripherally and continue what we are doing. Continue what we are doing. Clear on this? Simple, very simple things I am talking about. Septic shock, mean arterial pressure. We talked about endpoints of resuscitation and endpoints of whether the patient is improving or not, what your targets are all about. And what are the vasopressor of choice that we are looking at? Noradrenaline. And then if it doesn't improve, immediately I start with vasopressor. If it doesn't improve, I start adrenaline. I have to not wait. I can't just wait 8 ml, 9 ml. It doesn't make sense for me to come in the morning and say adrenaline chalu karo. You understand? Because we missed out a large list. This happens very often. I come in and say adrenaline chalu karo. Doesn't make sense. You have not improved. 10 minutes have passed because noradrenaline is titrable, no? It is immediate. Noradrenaline, if it is not working now, it is not going to work after 15-20 minutes. You will just keep slowly going up and then you are not going to go down. So now the question that comes is, what happens if the urine output doesn't come? You are at 65 MAP, you have done NORAD, you have done vasopressin, you have done adrenaline, urine is not coming. Then what do? Then I will give a trial of high MAP. I will go on a trial of a higher MAP. I will give a trial. It's called as an adrenaline trial. I will give a higher trial of MAP to see what is happening. Clear? So if from 65 I will go to 75 with the correct understanding that this doesn't really improve. There was a trial that looked at 60 versus 65. It didn't show a difference. You understand? It didn't show a difference, but I will try it out because I don't know if this patient is chronic hypertension. But I'm doing a trial after all. I'm not doing it as a rule. I'm doing a trial to see what happens. I'll go up. What is the problem of going up or doing that? The problem of doing that is there is a chance of arrhythmia. Why we don't want to do that? Because the chance of arrhythmia, isn't it? There is a chance of arrhythmia there. So it's not something I want to do, but I will have to give it a trial. When I give it a trial, I have to be there besides the patient to understand what I'm doing because it's titrable. It is titrating. You are titrating it within minutes, within seconds that will start going up, isn't it? You are understanding. So you can't say, "Chalo adrenaline chalu kar do, main dusra patient dekh raha hu." It doesn't make sense only. It doesn't make sense only. You have not achieved what you have to achieve. Samajh mein aa raha hai? Clear? Then as time goes, your adrenaline will come down. Then you can titrate again. You don't need 65 MAP. Once you have started that this patient is, that is a 65 as a target, don't put it in your head. For definition, it is fine. Okay, but say tomorrow you have started this patient, you have kept the MAP above 65, urine output is coming. Okay, now what are my targets? Capital refill and urine output is also there. And lactate and clinical status is there. Clinical status has got better, lactates are coming down. This is urine output is coming. I may want to reduce the MAP to 60. I can keep the MAP at 60 because urine is coming. Patient is getting better, lactates are improving. So 65 as a number, don't put. Others will say 65 is niche, 65 is niche, chalo, not bandi mat karo. Are you understanding? So it has to be personalized and individualized. Everything has to be personalized and individualized. Okay, for starting, definitions, guidelines, all these protocols are for starting. Afterwards, everything is personalized and individualized. Clear? Clinical status is most important. Clinical status. So when you are taking a history, a map, उसका map अच्छा है. अरे patient कैसा है? Patient कैसा है? That is the query we must ask. कि अरे how is this patient? Has the urine improved? Has his breathlessness come down? That's the questions that you should be inquiring on. Are you understanding? Your round should not involve इसको ये बोला sir. इसको ये करने को बोला, उसको वो करने को बोला. Clinical round has to be there. You can't be just a clerical round. Clerical round तो होना है हम लोग को. We all require clerical rounds. I also require clerical rounds. Okay, what has happened? What did he say? What did he say? That is important. Very, very important. But part of the story is clinical round. What you are lacking in your rounds is your clinical round. That is why you are not able to understand these things well. Are you understanding? Clinical round is important. What happened? Okay, what happened? You should start thinking like that. Okay, clear? Now comes the antibiotics. So it's very important to give the antibiotics early. Very important. Now, when I think of an antibiotic in septic shock, how am I going to think about it? I'm going to think about it of an antibiotic that is broad spectrum because I don't know what the situation is here. I'm going to think of a broad spectrum that will likely cover every organism. Out of that, usually the backbone has to be a beta-lactam. You can't give levofloxacin and leave it there. Okay, it has to be a backbone of a beta-lactam antibiotic. That has to be there. And if it is a severe, that is why you need to know what is there in your hospital, what is there in your community, or what is there in your country. You know, that is what you need to know. The reason to know what is there in your community, in your hospital, in your country is this. For example, if you have a patient who's in the hospital and 10 days later has come to you with this problem of pulse rate being up and yeah, stress patient, I need to know what is there in my ICU. I need to know what is there in my hospital. That's my antibiotics titration depends on that. So that's why that patient received a combination of 3-4 antibiotics. Got the point? Huh? So that has to be done quickly. So that is why I got irritable, because when the patient came from the floor, there was not a single antibiotic even ordered. This is a lack of education. Got the point? And we on the bedside, rather than actually telling to give that antibiotic quickly, we are taking over. Are you understanding? That antibiotic becomes so crucial, isn't it? You are understanding, Elizabeth? It becomes so crucial because whatever you are doing on the vasopressor front is only temporary. Whatever you are doing on the fluid front is only temporary. There is nothing that is going to help that. That is only to keep it on till the antibiotics work. Till the antibiotics, the more delay of the antibiotics, the more the problem. That is why the antibiotic should be the first thing going inside. Are you understanding? So the backbone has to be a beta-lactam. You can't have levofloxacin. You can't have oral antibiotics. Okay, whether you want to combine or not, that you can take a call with something else. Whether you want to give an MRSA cover, actually depends like that. For example, if you have urinary tract infection, I am not looking at MRSA, no. Nothing comes in the urine, MRSA. If I am looking at community acquired pneumonia, the community acquired MRSA is rare. It will have features, necrotizing rega, there will be blood coming here, there will be big cavity, all that will be there. It is not there. I will do any teicoplanin, no, I don't. Are you understanding? So I will have to think like this: which is the antibiotic I want to give to this particular patient? Clear? Then the next thing that comes up is heparin. Okay, we have septic shock. Heparin, DVT prophylaxis, very important. DVT prophylaxis, extremely important. These patients are in pro-coagulant states. All of them are inflamed. If they are inflamed, there are endotheliitis. If there is endotheliitis, there is going to be a pro-coagulant state. These patients may develop a deep vein thrombosis. Very high chance of getting deep vein thrombosis. So what do I need to give? Heparin. Heparin works multi-pronged. Heparin will also work in sepsis because heparin actually inhibits heparinase, and heparinase is responsible for the endothelial glycocalyx from going down. Our sepsis, our endothelium has got endothelial glycocalyx. What is happening in sepsis? It's leaking. Endothelial glycocalyx is broken, it is leaking. Okay, the heparin works dual. Heparin works because it actually causes the endothelial glycocalyx to become a little bit more stronger and prevents the leak. So heparin works dual. It works for DVT as well as it works for in the prevention of leakage, sepsis. That's why DVT becomes very essential. DVT prophylaxis becomes very essential. You understand? DVT prophylaxis becomes extremely essential here. Right? So we talked about the targets, we talked about the therapy. The rare therapies are not something we want to go to. There are other rare therapies, but we don't want to go to all those things. We want to be in this spectrum only. We want to be in this spectrum only. Clear? Any queries now? Septic shock? Any queries? So you should follow it like this. If you follow it like this, you will not make a mistake. Then you will not need to think in the exam what I must do. You have to understand definition, parts of the definition, my endpoints of resuscitation, my endpoints of patient getting better, what is my therapy, okay, what is my therapy, how quickly I have to do it, and what I have to follow up. So you can imagine when the cultures have not come in, how you can get irritable then. You should get irritable. Okay, cultures should be high. You should get irritable because why? That is what is going to define whether it's going to improve or not. If you have not sent the cultures, it becomes difficult. So when you send the culture, they are going to put it inside. If you send the cultures late, how is it going to come? Morning I said do a blood culture, and you send the blood culture in the evening hours. You have lost the day. Are you understanding? You have lost the day. It doesn't make sense because you need the cultures. Without the cultures, you can't do anything. Are you understanding? Any queries on septic shock further? Any queries? Nothing? So let's go to this topic.